This portion of the program is really to give you an introduction about why this entire area is so confusing and so difficult. Dr. Hitchinski in particular has tried to bring some clarity to chaos over the years, and he'll be talking about that in a little bit more detail during his presentation. But what I'm going to do to set the stage is first talk to you about some of the challenges we have in terms of trying to do research in vascular cognitive impairment and vascular dementia. Even those terms are now becoming potentially passé as terminology has changed over the years. And then we'll go on and talk a little bit about some of the epidemiology with all of those caveats that I'm going to talk to you about in mind. So first, some of the research challenges. I love this slide for this particular presentation. This is a morass, and this is pretty much where we are. A morass is defined as a soft, wet area of low-lying land that sinks underfoot. So the more you wade out into the middle of this nightmare, and you are here, the deeper and deeper you get, and the less clear things become. So first, the traditional definitions: dementia, cognitive impairment that interferes with daily functioning, leading to a loss of independence. The DSM-5 changed that and now calls it a major neurocognitive disorder. So DSM-5 did away with the term dementia and changed it into major neurocognitive disorder. But even this is not necessarily inviolate. Mild cognitive impairments, MCI, are cognitive deficits that don't affect daily functioning. It's people saying that they have problems with their memory or some other neurocognitive deficit, but it's still being able to take care of everything in their daily life. DSM-5 changes this to minor neurocognitive disorder. But for the purposes of the talk, because this is ingrained in my hippocampus, we'll still talk about dementia and mild cognitive impairment. So this is the first problem that we have. The first problem is that there really is no gold standard for the diagnosis. You know, whenever you're working or developing clinical criteria, you like to have some gold standard. That's how you figure out sensitivity and specificity, etc. But when there isn't a gold standard diagnosis, that becomes a little bit of circular reasoning. There are also other neurodegenerative conditions that often coexist in patients that do have evidence of ischemic injury or prior hemorrhage. So this further clouds the problem, and as I'll show you in a minute, this overlap, particularly between neurodegenerative dementias such as Alzheimer's disease and vascular dementias, it really is a Venn diagram. There really is an incredible amount of overlap between the two. This is probably one of my favorite examples of this. This comes from Chris Hewlett at Duke, where I had been for 30 years. This is a single high-powered photomicrograph from an autopsy specimen. And what you're seeing in the same high-power field, is ischemic pycnotic neurons, so neurons that have been damaged from ischemia, along with plaques and tangles consistent with Alzheimer's disease in the same high-power photomicrographic field. I think this is an epitome of the problem. If you saw this patient clinically before in life, and they had evidence of ischemic injury as well as a history that might have suggested Alzheimer's disease, what is it? How are you going to categorize that patient? Well, this is actually a heck of a lot more common than some of the than having either condition in an absolutely pure form. This graph illustrates that. If you're considering the degree of degenerative component here, and then the degree of a vascular component here, in some people, you have a more pure degenerative component to their cognitive impairment. This is a high degree of degenerative changes, relatively few vascular. On this side, this is folks who have a great deal of vascular changes with very little in the way of degenerative pathology. The problem is that many folks have a mixture, just as I showed you in that single high-powered photomicrograph. Now, the radiographic diagnosis is also uncertain. So you can have cognitive impairments from having multiple cortical infarctions. There can be small, strategically placed infarctions or hemorrhage, for example, in the caudate thalamus, the hippocampus, the perisylvian region. There can be subcortical or periventricular small vessel type changes. There can be hypoperfusion changes. And then there are also changes related to, for example, amyloid angiopathy. For example, a patient such as this who had no cognitive impairment and then has what are multiple embolic appearing strokes, the left MCA, the right MCA distribution here, they were normal one day and now they have troubles thinking. This isn't rocket science, right? So we think that those folks would likely have a large component of vascular disease that underlies their cognitive impairment. But patients can have this, for example, a small infarct in the head of the caudate. They could have hypoperfusion type changes. They could have changes consistent with amyloid angiopathy. They have relatively smaller changes in the white matter or more extensive changes in the white matter. All of these types of radiographic changes may all lead to cognitive impairment and different cognitive impairments or relatively no cognitive impairment. So the correlation between these radiographic changes and cognitive impairment is not always one-to-one. And radiographic evidence, even in any of these patients, of vascular injury doesn't mean that there isn't a concomitant degenerative component to their disease as well. So the two, as I showed you before, can coexist. Now, there are some general features that may lead one to think more of Alzheimer's disease versus a vascular dementia. For example, Alzheimer's, the onset is more often gradual, unlike that patient that I showed you where they're cognitively normal and then very rapidly become cognitively abnormal. With Alzheimer's, the progression is generally constant or insidious. In vascular dementia, more slower stepwise, although that differentiation can often be difficult. With Alzheimer's, focal signs are usually absent. In vascular dementia, the signs of stroke, it's usually present. In Alzheimer's, memory is generally affected early and more severely. In vascular dementia, it tends to be relatively more mildly affected. One of the larger or more important differences in Alzheimer's disease, executive function impairment, is generally occurring late, whereas in vascular dementia, it's more commonly early. And then in Alzheimer's disease, neuroimaging can be normal or show atrophy, whereas in vascular disease, we have the types of changes that I just showed you. But as any clinician will tell you, this very often is not all that helpful, again, because of this overlap. So how is this being defined then if we don't have gold standards for the diagnosis? Well, there's a lot of circular reasoning that goes on and a lot of opinion, a lot of consensus. So what this also does is make doing research in the area very difficult, because if we don't have an agreed upon diagnosis, then how are we categorizing patients? What's the phenotype? So for example, in DSM-4, the one that preceded the DSM-5 that I'll show you in a minute, for vascular dementia, there had to be clinical evidence of stroke. It has to be shown either by neurologic examination or imaging. You don't need to do both. And a temporal link isn't required. It's not like that patient that I showed you who was cognitively normal, blows out a hemisphere and now has problems thinking. In ICD-10, it's clinical evidence of stroke, again by neurologic examination or imaging, but now a temporal link is required, so that type of patient that I showed you. So in ICD-10, now there needs to be a temporal link. Now, as I said earlier, we now have DSM-5 that's replaced DSM-4, and the term dementia has gone away. It was thought to be pejorative in some way. So now it's a major neurocognitive disorder, vascular subtype, a lot more words to say the same thing. So it's one or more acquired significant impairments, that means loss of independence, in cognitive domains with evidence of vascular disease. The cognitive domains can be in memory, language, executive function, agnosias, visual spatial function, executive function, or in other higher order functions such as mathematics, emotion, or writing. Now, Dr. Hitchinski is going to talk about this in more detail. I'm not going to take much time with it at all now, because I know he will be. But the notion here was to develop some way of categorizing patients that would be generally acceptable. The scoring system considers the clinical onset as well as other factors, and depending upon the score, then one can categorize patients as either having Alzheimer's, a mixed dementia, or vascular dementia. The NINDS Arians criteria, also used for research, divides into probable and possible vascular dementia. For probable, dementia and stroke with the abrupt onset of dementia within 3 months and a fluctuating or stepwise course. Possible vascular dementia is dementia with focal neurologic signs. When neuroimaging isn't available, there's an absence of clear temporal relationship, or a subtle onset and variable cause of the cognitive deficit. So again, certainly for possible vascular dementia, one could certainly argue in individual patients, and from a research standpoint, what in those patients, how would you consider them in terms of epidemiology or other research studies? Now, another set of criteria, the Alzheimer's Disease Diagnostic and Treatment Center's criteria. Probable vascular dementia is dementia and more than 2 strokes by history, neurologic signs with or without neuroimaging, or 1 stroke with a temporal relationship with the onset of dementia. So we're turning into a restaurant menu, 1 from column A and 2 from column B. And then, or one infarct outside of the cerebellum by CT or MRI, which in and of itself is problematic. As you know, cerebellar disease can affect cognition, emotion, and other higher cognitive functions. Possible vascular dementia, and 1 or more of a stroke without clear relationship of onset. Still use the term Binswanger's disease, early onset of a gait disturbance, urinary incontinence, vascular risk factors, and white matter changes. So as you can tell, as I'm going through this now, how many definitions of these 2 conditions and different terminologies have we had? Think back to that morass that I showed you earlier. This is part of the problem. As you read through the literature over the years, different studies using different criteria, different definitions, it becomes extraordinarily difficult to get a handle on what it is we're talking about. So what one would like to do is try to validate a scoring system. That hadn't really been done. This is a study that was published back in 1997. It was based on 113 autopsied adults, 40 of whom were considered to have vascular dementia based on a combination of clinical and pathological criteria, 32 Alzheimer's disease, and 41 mixed. So a nice spread between vascular dementia, Alzheimer's disease, and mixed dementias. So what's the problem with these validation studies? We're back to that circular reasoning. What was the gold standard? It was that combination of clinical presentation along with pathology, which sort of makes sense. But then which of those is the absolute criteria? So in terms of the diagnosis of vascular dementia, in terms of sensitivity and specificity, with all of those caveats, you can see that for Dr. Hitchinski's score, the sensitivity was around 0.43 with a specificity of 0.88. The NINDS Arian criteria, 0.58 and 0.8, and the Alzheimer's disease criteria, 0.63 and 0.64. Sensitivity goes up, specificity goes down, and vice versa. For the diagnosis of pure Alzheimer's disease, that means that there's an exclusion of a vascular component. You can see the sensitivities and specificities there. So depending upon an individual study and what the goals are, you could choose one set or a different set of criteria and go for higher sensitivity or higher specificity. Now, what about diagnostic reliability? That is, Dr. Jaika there sees a patient and considers it to be X, and Dr. Hitchinski sees a patient and considers it to be Y. How well do we agree with each other with having those criteria sitting in front of us? So that's what was done in this report. There were 25 cases, 4 of which were considered normal. 4 had cognitive impairment with no dementia, 14 mild dementia, 3 moderate dementia, and 6 had a history of stroke. So a series of raters was given those same criteria, those same scenarios written out, and then asked to apply the different criteria and see how well they agreed. So the CAPA score for the DSM-4 was 0.59. You interpret that as showing only moderate agreement between raters. The Hachinsky score, the original and modified, you can see also in the moderate to substantial range. The NINDS Aryan criteria, 0.41, 0.15. So for probable, it was in the fair to moderate range. And possible, it's only just slight agreement between the raters. And then the ADDTC criteria, probable and possible, around 0.42, so fair. So the morass is getting a bit deeper, right? So you have written criteria. You guys can't agree with each other applying those criteria to a written case, let alone taking a history and dealing with all of the vagrancies that we have to deal with in the actual clinical world. But then even when we come up with one of those criteria, how well does that fit? How valid are they? That is, how well do they reflect reality? One of the approaches that was taken to try to at least come to some degree of clarity, and again, Dr. Chinsky is going to be talking about this in more detail, is the VCI harmonization standards that really focus in on executive dysfunction with a clear set of ways of assessing and grading that degree. But again, Dr. Chinsky is going to be talking about that. So just as we thought that things were going, at least we had data, we had sensitivity, specificity, we know a little bit about validity or don't know about validity, we have some data on agreement. The field hasn't sat still. This is the VASCOG consensus statement that was just published in 2014. So again, it's a bunch of people getting in the room and deciding what's reasonable. So the criteria were firstly establishment of a cognitive disorder, which would consist of a subjective report of a concern, somebody saying I have a problem thinking, and then objective evidence of an impairment in one or another of the different domains. You have to establish a predominantly vascular etiology, either by neuroimaging showing infarction, hemorrhage, or white matter abnormalities, also based upon history and neurologic examination showing some focality, and also excluding non-vascular causes. Well, we just went through all the problems with this. And then certainty, probable vascular cognitive disorder, again, another term. Both clinical and neuroimaging criteria have to be met, and then possible clinical criteria met, but neuroimaging isn't available. So again, another consensus statement with new definitions, new terminology. This hasn't been tested in terms of either validity or inter-observer agreement. So just this entire field is going to continue to remain a bit mushy until we do come to some overall agreement in these, which I thought we had done, but obviously not. So just one last point about this, just to add a little bit more confusion or a little bit more clarity, is as years go on, what we're learning is that the overlap not only pathologically and clinically between the neurodegenerative dementias and vascular dementias is pretty extensive. We're now learning more that even the risk factors for what we consider to be Alzheimer's disease and vascular dementia, with all of those caveats in mind, seem also to be overlapping. Advancing age, hypertension, cigarette smoking, coronary heart disease, diabetes, ApoE4 genotype, possibly dyslipidemia, possibly elevated homocysteine, possibly obesity, are risk factors for both vascular disease and Alzheimer's disease. Now, there may be some common pathophysiology that explains that. That is, vascular injury may lead to increased AD-type pathology. So you have arteriosclerosis or atherosclerosis. It can lead to reduced perilymphatic drainage that then reduces amyloid clearance that then leads to increased AD pathology. The arteriosclerosis also leads to hypoxia or ischemia. That affects tau phosphorylation, increased APP cleavage. That also leads to increased AD pathology. So this overlap that we have in terms of pathology and diagnosis may also have some common pathophysiologic overlap as well. So this is where we are. We have in our classic thinking, if you're an Alzheimer's person, you attack all of this from the standpoint of Alzheimer's disease. If you're a vascular neurologist, we attack it as all vascular disease. But the truth is both diagnostically, pathologically, and maybe pathophysiologically that there is this tremendous overlap between the two. From a research standpoint, as I tried to point out, we have no gold standard, right? That there's no gold standard pathologically, radiographically, or clinically. And the groups involved in doing active research area keep changing the terminology and changing diagnostic criteria that when we test them against what seems like a reasonable gold standard, that we're really not doing very well, either in terms of agreement or validity. Again, the one way out was at least to come to some common agreement that Dr. Hitchinski is going to be talking about. So now let's take so with all of this confusion now, how are we going to approach this? One of the areas is in epidemiology, right? So we say that the prevalence of vascular dementia doubles for every 5 to 10 years over age 65. The prevalence is 1 to 4% after age 65. So these are the numbers that are quoted, but where are they coming from if you're not sure of what even the diagnosis is? You know, it's a bit artificial. It's considered to be the second most common cause of dementia worldwide. 4 to 22% of dementias in the West, a nice little confidence interval there. It surpasses Alzheimer's disease in folks over age 85. In Japan, more than 50% of the dementias are considered to be vascular rather than neurodegenerative. Dementia occurs in about 20 to 30% of folks about 3 months after stroke. An additional 25% develop dementia over the next three years. Is that because of additional vascular disease, or is it because of some of the pathophysiologic changes that I just showed you? That we don't know. About 50% of folks with vascular cognitive impairment progress to dementia over the ensuing five years. So the epidemiology of dementia is changing. This is from the Framingham cohort study that was published in the New England Journal just earlier this year. So one thing that you're seeing, firstly, is that as the decades go on over these three decades, these Framingham epochs from 77 to 83 to 2004 to 2008. Is that many vascular risk factors are improving, and treatment of them are improving. For example, if you just even focus in on cigarette smoking back in 1977 to 83, about 20% of the Framingham cohort were smoking then. It was down to 6% in 2004 to 2008. The use of lipid-lowering drugs, other treatments for hypertension, for vascular disease, have also been increasing over the years. At the same time, the incidence of Alzheimer's disease has decreased, the incidence of vascular dementia has decreased, and the incidence of all dementia has decreased. Over this period between 77 to 83 to 2004 to 2008, it was estimated that there was about a 40% reduction in new onset dementia in the population. Part of this, although not all of it, was explained by improvements in control of vascular risk factors. And given what we know now, it's not surprising that that would have at least some contribution. But there's a lot more going on because not all of this decline was explained based on control of vascular disease. So what I try to do in this first little part is really sort of set the stage for you and give you some background as to why this whole area has been so confusing over the years. What Dr. Hitchinski is going to do is try to bring some clarity to all of this in his presentation. And then Dr. Jaika, when he talks afterwards, will be talking more about what some of the therapeutics are, what some of the new therapeutics are and approaches for vascular dementia, vascular cognitive impairment. Again, allowing me to use those terms as opposed to one of the other now probably 3 or 4 terms, depending upon which authority you listen to, we should be using for these. So I have just time for a few questions now. We'll have a few questions also between each of the individual talks, and then we should have some time at the end as well. Any questions from anybody first? If not, we will get on with the meat.